Right. All right, so it's 12 o'clock. We have Josh back talking about boosters and beyond, building QI resilience, session 6, Casper and SARS reports, using data to drive improvements. We're very excited to have you all back, and I'll just turn it right over to Josh.
Perfect. Thanks so much, Melanie. So, of course, we start every session talking about who we are. We're the iPro QIN-QIO. iPro is the company that holds the federally funded QIO contract for 12 regions across the United States. They themselves cover New York, New Jersey, and Ohio, and have contracted with health-centric advisors in Clarence to help support Connecticut, Maine, Massachusetts, New Hampshire, Rhode Island, and Vermont, as well as Maryland, Delaware, and the District of Columbia, respectively. So if you hear the name iPro, or if you are talking with someone from health-centric advisors in Clarence, and then someone asks if you know who iPro is, if you talk with any one of us from these organizations, you know who iPro is. So with boosters and beyonds, we'll still want to start our sessions a little bit about talking about boosters in some fashion. And I thought it might be a really good idea to start to bring up some of the facts and myths that we hear a lot from our staff and even residents. And there's actually this great web page on the CDC website that lists several facts and myths and poses different examples that you then, of course, can take back and share with the rest of the team or the residents themselves. So this first example is on the myth versus fact, whether COVID-19 is the vaccine actually is to blame in causing the variants. But we know that the virus is constantly going through a process of mutations and changes, and that when it infects people, there's that chance of the mutation and change. And throughout this virus is constantly evolving. So I have another example here. There's a myth. The natural immunity I get from being sick with COVID-19 is better than the immunity I get from COVID-19 vaccination. And this is the one that I actually hear from not only from other people at facilities and staff and everything, but even people I know in my personal life as well. So there's a lot of information to support that COVID-19 vaccination is safer and more dependable way to build immunity to COVID-19 rather than getting sick with it. So again, there's really great resource on the CDC website. Really encourage you guys to take advantage of it if you haven't already done so. And we really need to take a look at, as we continue to push these boosters, we really need to understand that we're at that slow drip in uptakes for the booster, but we have to continue pressing forward. There are going to be those that are continuing to be hesitant, that really fall in the middle of this diagram, and their hesitancy really refers to a delay in acceptance or refusal of the vaccine. Vaccine hesitancy really is a complex topic, and it varies a lot. So when you look at this diagram and you think about the people, the staff members and residents who are hesitant to get that booster, you really need to start to consider, we always talk about resident-centered approaches, but even like staff-centered approaches, where we need to tailor our approach for each individual staff member specifically based on reasons why they're declining to get the vaccine and everything. There's no single strategy at this point that's going to help us get the remaining number of people. So just wanted to start off the session, boosters and beyond, just to talk a little bit about boosters. And we're going to get into today's topic to talk about utilizing data to drive improvement. So here are a couple of learning objectives. We are going to compare different data sources that you have available at the skilled nursing facility. And we're going to review sort of a person-centered process for quality improvement and improving your quality measures. And then a quick example on analyzing data-driven quality improvement in action. So first step is to collect your data and know what your data sources are. So the nursing home has access to a multitude of different data sources, and all with different types of data, a lot of it the same, a lot of it different. But within your facility assessment, you should be really identifying annually the unique kind of populations that you serve, and tailoring your services to support and meet those needs. So when you're working on quality improvement, I actually like to take a look at your facility characteristics report within Casper first, just to see if your current population is still matching with what your previous facility assessment is. I'm going to get into an example in a little bit, but there's a lot of different things you can see on that characteristics report. The average gender in the facility of residents, the age group, percent of residents who have a psychiatric diagnosis. And that really gives you a quick snapshot regarding the population that you serve. We also have the standard analytic report. So we at the QIO, because we're contracted by CMS, they provide us with facility claims-based data for each facility that's part of our collaborative. So we actually generate these reports based on the claims data, and can actually show you some historical trending data for each of the quality measures. So if you aren't already receiving these reports from us, I definitely encourage you to reach out to us so that we can help ensure that you get your reports, because it's a fantastic resource to help, see. Particularly helpful because, since like I said, it shows that historical data, you can use that to help pinpoint when you've implemented maybe specific interventions or performance improvement projects in the past, to see if you've actually made positive improvements with them. So as I mentioned before, this is the facility characteristics report. And like I mentioned previously in the last couple of slides, you're able to go through and really understand your population that you're currently serving. So in this example, I've gone ahead and highlighted a couple of the points where the facility is sort of having the higher percentage compared to state and sometimes even national averages. So in this instance, the facility has a higher population of males compared to the state and national average. So what do they do? How are they tailoring their care? Are they maybe utilizing more male support staff like CNAs and everything to help support? Or how are they managing their activities to meet the interests of the gender? You can see too that the age groups, there's a higher population of the 55 to 64, 65 to 74, and then 75 to 84 compared to the state and national averages as well. So I've gone ahead and sort of given us a snapshot of what the population currently stands based on that report, and you want to make sure that your facility assessment that you do annually still is holding true to how the populations that you currently serve today.
Josh, we have a couple questions.
Sure.
So the first one was, who do I reach out to receive the SARS report?
Sure. So I have contact information at the end of the slides that you'll be able to reach out to any one of us for the standard analytic reports, so we can help you.
And then also, does Casper capture resident vaccine information?
I'm not sure. I know that you're submitting MDS information for the flu and pneumo vaccinations, but I don't know. I'll have to double check, or if anyone else on the team knows if it's captured. I'll have to double check from my end.
I don't know off the top of my head, but we'll find out. And yeah. I did put in chat just to question who runs the Casper report in the facility, so people are answering that as well.
Yeah, typically from even my own experience, the MDS coordinator is usually the ones who have it at the tips of their fingertips, just from my own experience, but I'm not sure what else people had mentioned maybe in chat. Quality
department is one so far.
So when in Casper, there's also a resident level report that you can pull up, and when you're determining areas of focus to take a look at, you can actually take a look at and see how they're affecting each specific resident. So for example, when you look at the resident level summary report, you can see quality measures for each specific resident that they triggered for. So I really recommend taking a look at the number of quality measures each resident has triggered for. You can see that at the end, the total number of quality measures that they're triggering for, and make a short list of residents who maybe are triggering for 3 or more quality measures. And that way, maybe you can identify 1 to 3 residents to start focusing on, preferably on the same unit that you're going to be implementing a performance improvement project on. So when you're starting to take this approach, it'll not only help you hone in on some trends and issues on the same unit, but also help work to maximize your standing on your 5-star rating. So I went ahead and used this as an example of, if we're going to be working on antipsychotic medications, I went through and highlighted all the residents that are triggering for antipsychotic medications. And additionally, I also highlighted the quality measures on the side for those individuals who are also triggering for 3 or more measures. So this is where it gets really interesting, because all these individuals who've triggered for antipsychotic medications and are triggering for 3 or 4 measures, look how many are also triggering for falls. 1, 2, 3. This one thankfully isn't triggering for falls, but this one is as well. A lot of these quality measures have a domino effect upon each other. So when you're working on to improve one quality measure, you can actually see an improvement in the other ones. So we know with antipsychotics, we often see other quality measures trigger alongside that, such as falls, anti-anxiety, and even behaviors. And what's always really is astounding to me is all the individuals who are triggering for behaviors, despite receiving the antipsychotic medications. So it really poses the question, are the medications even being effective at this point in helping prevent their behaviors affecting other residents? So a lot of interesting things that you can go ahead and find when you're doing this deep level of analysis and comparing that with the other quality measures that they might be triggering for. This next slide here, Dennis, I want to know if you wanted to chime in on these next couple of slides.
I would love to, Josh. Thank you. So we've discussed specific quality measures during the series and how it affects the facility 5-star. However, we also wanted to take the time to fully explain the purpose of the quality measures and the different types of quality measures that represent the performance, care, and impact on the patient or resident. Quality measures are actually created to address the 6 domains or aims of healthcare quality, ensuring care is safe, effective, patient-centered, timely, efficient, and equitable. So quality measures can include health outcomes, clinical processes, patient safety, efficient use of resources, care coordination, patient engagement in their own care, patient perceptions about their care, as well as population and public health. Next slide, Joshua. There are different types of quality measures. There are many elements of data that are reported that are actually quality measures. Structured measures assess the infrastructure and resources of a facility. When we report the ratio of providers to residents, or RNs to residents, or nursing hours per day, that's actually a quality measure. Process measures reflect the steps that occur within a facility and between providers in effort to provide care. Examples being the percent of residents who have had immunization, regardless of where they received it, the percentage of residents with diabetes that have had their blood sugar tested and it's controlled. It demonstrates a coordination of care. Outcome measures reflect the result of care we have provided. Are we making the intended outcomes? Are there adverse drug effects, which are negative outcomes, or successful discharges, which would be the positive outcomes. And then there's the patient-reported outcomes and performance measures in the form of surveys, and these reflect if the care we provide has value and what the customer's thoughts are regarding the facility's performance and care. Next slide, please. So here's a simple table to show some of the different types of quality measures, what's measured with examples, and what aim of from the 6 domains and aims of healthcare or quality is addressed. You know, I'm not going to spend time on this, but there, if you're interested, you can go to the AHRQ website, and they talk about all about the different types of quality measures, what falls into the quality measure. So we just wanted to bring that up, that there's different types, and you don't necessarily realize that, you know, your staffing and some of the other things are actually reflective of your quality measures. Thanks, Josh.
Thanks, Dennis. I appreciate it. So like we mentioned, we're going to be doing this whole series on various different quality measures. So keeping and understanding that not necessarily all of them are tied to outcomes. You need to understand that a lot of them could be related to structure and process, etc. And so when we're going through our resident line listing and identifying which residents are triggering for a specific quality measure that we want to work on, we can then hone in specifically on very specific residents and then create performance improvement projects that are not only going to address the quality measure itself, but like we can tailor these performance improvement projects almost like as if they're patient-centered, derived, like focusing on these specific residents. And we actually had an exercise that we wanted to share with you guys. We actually have an exercise, like I mentioned. It's the cause and effect or fishbone diagram. And sometimes when we think about quality improvement, our minds are really running around trying to track all these different things, tracking infections, setting up elaborate programs to improve process. But quality improvement itself can be really simple and put into a really simple tool like this one. So the cause and effect diagram, so that your team can go ahead and brainstorm ideas and make decisions about changes that might improve care or process. So a positive change can become essentially a team sport when everyone's voice is heard and everyone's involved. We had a series previously on finding the joy in work, and a lot of that had involved participative management, where we're really eliciting the participation of our staff and having them become part of the solution, making sure that everyone's heard and have an opportunity heard to offer their best. We actually had a session, we went on a road show, and this was, I believe, up in Maine, where we had directors of nurses and administrators come up to tackle a problem that we had used as an example. And look at how amazing it was to have like people not only from different organizations come together to solve this issue. Imagine the impact of, you know, doing something like making quality improvement fun like this within your own facility to impact the residents within your own facilities. So this example, like I mentioned, they're working to solve a big issue that has caused a great deal of challenge for the team, and they're working it out through the cause and effect of fishbone diagram. But there's a couple of instructions to go about utilizing it. You want to, you know, make that fishbone diagram, make it fun, take out some constructors painting tape, put it on the wall like what was on the picture, and put a couple of bones coming off the center. And that's usually enough, which will become the categories. And then you'll go ahead and, you know, label the different categories like workplace practices, environment, care practices, clinical care, leadership practices, and see some of the issues that could be tied to those different types of categories. So I filled out as an example what strategies might be utilized to increase booster acceptance within our setting. So, you know, we can talk about workplace practices, care practices and solutions that could be tied to each of these different categories to ultimately put together some ideas for quality improvement that we can test ideas of change. So I wanted to put up in chat for you guys, what tools or quality improvement tools and resources do you use within your facility? There's the PDSA cycle, process reliability tool, Swiss cheese model, failure mode and analysis. There's a lot of different things that you can utilize within your own facility that every tool works differently for each facility and team. So I'm just curious to know what some of the quality improvement tools and methods that some of the people on the call are using. And then because our session today is only a half hour and going through the using data to drive improvement, I wanted to leave you guys with additional resources related to this topic. So we actually had developed a Casper 101 video that's fully narrated that you can watch on YouTube. And it goes into a lot more depth than what I've gone into about you understanding your Casper data, looking at your resident level data, and you utilizing the culmination of all that information in that deep dive to really build an effective data review process that you can use to drive improvement. So I'm going to see if I can get this link for you guys. Give me 1 second. I want to make sure I put this in chat for you guys. Apologize. Thank you for your patience. And the link did not work in there.
Let me try it this way, Josh. I think
Okay.
I've got
Okay.
it to the web page.
Sure. So I'll let Melanie go ahead and put that in for us. Thanks so much, Melanie. Really recommend you guys taking a look at that. Like I mentioned, it does take, it's a longer video because we only have that half-hour session with you today. Really recommend you guys checking it out. So Melanie mentioned also that we actually have a session coming up later this afternoon. It's called Great Shot, Making Your Vaccine Campaign a Slam Dunk. And it's today at 2 o'clock. And we had put it within August and today because August is Immunization Awareness Month. And we want to make sure, that your team is armed with the tools and strategies to help you guys launch an effective vaccine campaign. So the session, they have a couple of goals in the session. They want to make sure that you have a good understanding and recognize the disease burden of influenza, pneumo, and COVID-19. I'm sure many of you already know on the call, but it may be helpful to have some other people participate as well so that they can have access to this information. We're also going to be talking a bit about the strategies to help increase the vaccination rates within the facility, and then identify recommendations for the adult population. So there's you can scan right now that QR code if you have your phone with you, or Melanie, I'll give you a chance to put the link into chat for people if they're interested in participating in this session later this afternoon as well.
It is in chat.
Perfect. Thanks so much, Melanie. So at this point, I really sort of want to just open up the line for questions because I know we had just sort of briefly touched the tip of the iceberg on this topic and wanted to make sure that everyone has an opportunity to pose some questions. I saw Darlene had shared that the Casper report will show influenza and pneumococcal vaccination status for both short and long stay residents.
I'm curious to know how the facilities are using it. If anyone's interested to unmute your phone or put in chat, how do you use it? Do you pull it monthly? how often are you pulling the Casper, and then what do you do with it?
Yeah, I mean, as part of the QIO, I've been to several QAPI meetings, and from my own experience, a lot of facilities, they pull the Casper reports and it's like, oh, we're triggering on antipsychotic medications. We need to work on that. But there's not really like a follow through or a connection to where to start. It's like this data is right in front of us. It's telling us that we have a problem, but how do you turn that data into something actionable? And I feel like that's some of the things that I've noticed facilities kind of struggle with. So I'd be interested to know how, like, do they take that same level of approach of going through the resident level report and, you know, going resident by resident, seeing who's triggering for maybe antipsychotics, but then also triggering for, you know, falls and behaviors, and how does everyone on the call go through that process?
I will say, when I was working in a facility, we would take the resident level data. The nurse manager would take a heavy look at that and make sure, especially the people who had multiple flags, to take a look at the medications with the providers, assessment, take a look at the care plans, making sure we're connecting why they're on an antipsychotic, but yet they've had falls. So a real deep dive in those folks that were scoring for 4s and 5s. I saw Dennis came off mute.
And then I started typing. My facility historically would take somebody that had numerous triggers, and like once a week, the entire IDT would review that person, you know, top to bottom, and really dig deep and see, you know, for that entire week, evaluate everything and see, you know, if they were on an anxiety or depression medicine or antipsychotic. Was there an opportunity? Were they having behaviors? Did we have non-pharmacological interventions? Were they working? Were people using them? You know, what about their bowel and bladder? Did they have a schedule? I mean, literally every single thing in the resident level, everything on the care plan, and see if we could tweak something just to address one of those or multiple factors.
Thanks, Dennis. I see John had put into chat a good hack that I have learned about is on Tuesday, you can run a report using the Monday prior as both the start and end date to get a snapshot of what's going on in the facility without the discharge resident data. Thanks, John. That's a really helpful tip. And I mean, like I mentioned before, we have a multitude of data sources available to us at the skilled nursing facility. There's so many different data sources, but all those data sources are useless if we don't actually do anything with it. So hopefully today you've gotten a snapshot into some of the processes that we take when we start to analyze the Casper data and drill it down to very specific residents and create resident specific performance improvement plans to ultimately tackle and improve that quality measure itself. And we start that at the resident level. So we invite you guys to contact us. I'm providing you guys with our information so that you can email us. Again, if you aren't receiving your standard analytic report and want to get those reports from us, make sure that you jot down our information and reach out to us and request to have access. And of course, if you have any other questions related to quality improvement or the quality measures, make sure to reach out to us. We're here to help support you. And if you aren't already part of our Nursing Home Quality Collaborative, we would invite you guys to enroll your facility as well. So reach out to us. We're available. And that'll be it. Anyone else? Dennis, Melanie, do you have any other announcements that you wanted to share?
Thanks for coming.